Well, hello everyone. Welcome to chapter 5. So this next chapter and the chapter that follows just really starts to get us familiar with movement, right? So we've been talking about these different terms that we need to be aware of as we converse with other health and wellness professionals. And this will kind of go right along with that. We're going to be discussing what happens within the joint whenever we move. So I want you to make sure that as we discuss these points, that you're distinguishing in your mind that we are talking about what happens at the joint and not what happens at the muscle. So I'll kind of compare and contrast those in a moment, just so that you're aware. And then also, like before, I am going to keep this screen smaller. I hope that that's okay with you guys. It just helps me to navigate and be aware of which slide I'm on, what's coming next, and engage appropriately. So let's first just talk about what in the world is a joint. A joint is where two bones meet and they have the ability to move. So think about how much movement and stability and that limited shock absorption you get from just being able to bend and straighten your knees and elbows. We're not like, stick figures, right? That are just solid mass and they kind of have to waddle side to side. Think of those little cartoons that we've seen maybe on Disney or something like that. We're movable beings. So we can go have these large expressions of range of motion. And that's thanks to our joints. Yes, muscles, tendons, all the other things, but we get that from our joints, the ability to. All these finite movements that we're going to be discussing, as well as the big eyes, it comes from our joints. So let's talk about the difference and types of joint movements. And you probably never thought of it this way, but I'm going to bring this to your attention. We have two different types, physiological and accessory. Physiological, I want you to think of these as the big ones that you can see. It's an active muscle contraction that stimulates the ability for this joint to be able to move. Again, I know I just said muscle as well as joint, but again, this is happening within the joint because of a muscle. Accessory movements are the little bitty movements that we can't necessarily see as much that happen in regards and because of and cause physiological movements. Accessory movements can't really happen on their own. We need to have the physiological movements in order for the accessory movements to happen, and the accessory movements help the physiological movements occur appropriately. And we'll get more into that in a moment. But let's just go down the basic list of physiological movements. Many of you have probably heard these. Flexion versus extension. So this is the decrease of a joint angle or increase of a joint angle. And this is where I like to make that little disclaimer that a flexion of a joint versus flexion or flexing a muscle. Does that make sense? Like, yes, flexing a muscle does increase or decrease the joint angle, but we're talking about within the angle, flexion recurs to decreasing that joint angle. I know it's semantics, but I always like to point that out. Extension means that you're increasing the joint angle, and hyperextension means that you go past what would be perceived as anatomical limitations. A great example of this is some of us can hyperextend our elbows to where you go beyond 190 degrees or 180 degrees, excuse me. And you can see that here in this picture that I put, but that's the difference between flexion and extension within the joint. Abduction versus abduction. So abduction, I always say AB versus AD, it helps us distinguish, but abduction means that we're taking a segment away from the body. So it's like abducting or abducting someone. You're taking them away from where they should be. Adduction means that you're adding the joint or body segment towards the midline or bringing it towards the midline. So adding it in. Hopefully that it helps you to distinguish, but it's always easier to be abduction versus adduction versus trying to stay it without that kind of emphasis. Internal medial rotation, this means that you're rotating a joint or body segment towards the midline, which makes sense, right? With medial or internal, and all kind of paints that same picture. Versus external or lateral rotation means that you're rotating the joint or body segment away from the midline. Elevation versus depression, it's kind of exactly what it sounds like. We can see it actually depicted here in this gentleman's shoulders. Elevation means superior movement, so movement up. Depression means inferior movement or movement down. So to me, it's synonymous with what it sounds like. You elevate versus depress something. Supination versus pronation. We probably heard about this in the foot, but the same action actually happens in our hands. And the wrist, you have either you are rotating the forearm from the thumb medially to the thumb laterally. So I always think of supination as you're putting your hand out to hold a cup of soup or hold a cup of coffee. Versus pronation, that means that you're pouring out the cup of coffee, pouring out the cup of soup, and you're rotating that thumb inwards and turning the palm down. Hopefully that makes sense to everyone. Again, it's a physiological movement. So it's not just the static posture, it's the movement to get there. So that rotational movement, again, turning the thumb out to receive that cup of soup, and then turning the thumb over, palm down to pour out that cup of soup. Hopefully that helps to distinguish that as well. Plantar flexion versus dorsiflexion. I always distinguish this one as you're like stepping on a gas pedal, or your knee jerk, you're taking that foot off the pedal. Plantar flexion is stepping and flooring it, stepping on the gas pedal, versus dorsiflexion is pulling those toes up towards your shins like you just stepped on hot coals. So I want to distinguish something here. We probably heard of these, or at least have thought about how you can point and flex your foot. But this movement occurs at the tail crural joint. And this is important whenever we talk about our next one. But I want you to make sure that you understand that within this ankle, you are able to do multiple planes of movement, okay? Sagittal, frontal, all the different ones. So with this one, it's that tail crural joint, and you're putting your toe down or pointing your toe up. Because then you have this lateral deviation, inversion versus eversion. And this has to do with the calcaneus. So think of this as the heel bone, if you're unfamiliar with basic anatomy, okay? So the calcaneus is your heel bone. This refers, so inversion actually is where that calcaneus rotates to where the sole of the foot is towards the midline. So this is your classical lateral ankle sprain, yeah? It's seen right here in this top photo. It's where the sole of the foot or the base of your foot turns inward, and that heel goes down laterally or out to the side, rotating out. Those of us who have played soccer or maybe basketball, you might be familiar with this one. Eversion is basically the opposite. This one's seen more in basketball usually. I see this a lot more. This refers to basically going the other way. The sole of the foot goes to the outside and your ankle rolls inward. Again, both of these are not fun, but it shows that we have this naturally occurring. There's too much of a good thing and that causes injury. But the inversion versus eversion is just that lateral movement of the calcaneus. All right, so supination versus pronation. Whenever we have these two movements, it's important to talk about that this is happening in simultaneous. It's like a combined movement. Remember how we had the supination versus pronation in the hand? Well, now this is at the feet, and how our feet go, we have this talar dorsiflexion and then a calcaneal inversion for supination. So what does that mean? That means that there are multiple different movements happening within this ankle between the several different bones in our ankle. So if you're like, okay, my brain just hurts from me saying that, let's break it down. So supination, this is the combined movement of talar dorsiflexion. So you remember dorsiflexion, that was where your toes pull up towards your shins. So visualize this with me, toes pull up towards your shins. Abduction, if you remember, that means taking that away, and then calcaneal inversion. Again, so we're taking that talar, so the upper part of the ankle, the upper bone, that upper joint is going up towards the shin and outward, and then the calcaneus is going inward. Hopefully that helps you. And here's a picture right here. So we see the talar dorsiflexion, so it's going up and out, and then calcaneal inversion. Then pronation is just the opposite, okay? So we have pointing of the foot at the talus, that talar plantar flexion, a deduction, so it's coming towards the midline, and which makes sense because if you think about it, it has this talus rolls inward, the heel is going to point outward. So you have the eversion at the calcaneus. Hopefully that makes sense to you. Feel free to message me or email me if you need any help with that. This one's pretty easy. Radial versus ulnar deviation. Basically, which way are you taking the hand? Are you taking it towards the ulna or towards the radius? Radial deviation towards the thumb side, ulnar deviation towards this pinky side. Protraction versus retraction. This is seen beautifully here in these shoulder joints. So we see a protraction means that you're moving that joint anteriorly, so forward, versus retraction means that you're pulling the joint backwards, so posteriorly. This is very important whenever we're talking about shoulder mechanics. That's whenever I use it the most, and you can really see it here. And this poor soul with her winging scapula, I'd love to get a hold of those and help her with that. All right, so opposition versus reposition. This one's pretty simple. It just means that you brought the pinky toe and the thumb together versus taking them away and returning to anatomical position. So opposition, you're taking opposites with the thumb and the fifth together, versus reposition, you're repositioning them back to start. That one's pretty easy. It's just not really memorizing, but understanding that visualization. Now let's talk about the hips. I could talk about the pelvis all day, but I'll try to limit it just a little bit for today. The anterior tilt versus posterior tilt. I like to think of this, and once you see it, you can unsee it. The anterior pelvic tilt is kind of like, I call it model butt in all my clients, where you can kind of see their pelvis just tipping forward. If the top of their pelvis was holding soup, it would just spill out forward and their butt goes back. Models do it all the time. Like whenever they're walking the runway, their butt's out, ribs up, and you just kind of see that anterior tilt all day. Versus posterior pelvic tilt, think about a scared dog. Or think about, this is going to really paint a picture. Think about if you were trying to squeeze a $100 bill between your butt cheeks. Yeah? Not letting it go. You're going to notice that that tailbone tucks underneath you, and you get that posterior rotation of the pelvis. And of course, you can see that right here. I always laugh at this graph, though, or this picture, because it says neutral pelvis. I wish I could just implant some quotes over that, because neutral pelvis is kind of all relative. Lateral flexion versus forward flexion. Think about how the spine can move in so many different ways. It gets some bonus things as well as the shoulder. Lateral flexion, think of this specifically the spine, how you can take your ears side to side. That's that lateral flexion of the head and neck. Forward flexion, that's where you can bend down and touch your toes, right? Like, it's crazy. Some of us, maybe you stop at knees, maybe you can palm the floor, but you have that forward flexion of the trunk. Horizontal abduction extension versus adduction and flexion. Think about it being those movements just straight out to the side. Yeah, we're just those typical movements. We've just taken them out to the side, just like you see in the horizon. Circumduction. So basically, like without oblique plane, we combined a bunch of movements to make a circular path. So we have the circular pattern. I always can visualize, you know, the old school 70s, 80s, Jane Fonda style exercises where they would do the ballistic type arm pumps. Well, they used to do arm circles. That's a circumduction movement. And as you can see by this picture right here, it's just arms right out the side and making circles. Rotation. So this is, you think about the spine, how you can twist and segmentally, these coordinated movements happen all the way up the spine, and we're able to rotate around our, along the spine all the way up, just like this gentleman is doing right here. Again, we're talking about like physiological movements that are occurring appropriately. And I put some YouTube videos, because if you're like, wow, that was a lot, you feel free to rewatch this after we get done with everything. But I also put a few other videos here. So here's a link to a YouTube video that's really good about explaining all the things that we just explained. So hear it from someone else. And then I also put what we're about to talk about, the roll, spin, glide, and the concave, convex. These two are going to be very visual and help you just to see what we're discussing. So make sure that you download this PowerPoint and click on these links because it'll really help you, especially the convex, concave video, because a lot of us have a tough time conceptualizing and visualizing this 3D concept that I'm about to throw at you. So don't forget, jot this down, click on this. It'll be a great tool for you to just concrete this information. Cool, you ready? All right, so types of accessory movement. If you remember, physiological movements were the ones that we could really see, like flexion, extension of the arm. Yeah, we can see that. It's those big, beautiful movements. Well, accessory movements, it's just like an accessory to an outfit. It helps pull and tie the outfit together, but with the accessory joint movement, it helps this joint physiological movement happen and happen appropriately. And it doesn't just happen on its own. So first of all, let's talk about roll. This is where several linear points on one joint surface comes into contact with one joint surface on another bone. And it just rolls in a linear fashion. So think about if I had a stable leg, like my foot was on the ground, and then I bend and flex at the knee. I have a fixed tibia and my femur is rolling up and down as I bend and extend my knee. Hopefully you can kind of visualize that, but it actually happens at the joint level. It's not just flexion extension, it's actually assisting in that flexion and extension because the roll is occurring within that joint space, okay? Again, trying to think of this a little bit differently, and if you're not visualizing it, don't worry, go watch those videos. Spin, this one we can really see whenever we look at the spine itself. One joint is rotating on the surface of another about an axis. So if you hold your fists together and then you spin them and rotate them in opposite directions, that's kind of what I'm talking about. And we see this along the spine. Think about whenever you rotate your shoulders side to side, within as each vertebra rotates on one another, you have this spin within the joint space. Again, we're talking about that little bitty motion that occurs, and it can occur in several different ways throughout the body. The spine is the one that you could almost perceive that the best. Glide. So this one's kind of neat because it could be seen as two different things, where one joint surface translates across another, or both joint surfaces are translating in opposite directions. Okay, so think about, we'll talk about this later, but whenever I do an ACL exam on somebody, if I think that they have torn the ACL, I run out on the field and I do an anterior, what's called an anterior drawer test. And basically I grab their lower leg, stabilize the upper leg, and I translate that tibia towards me anteriorly. I glide that tibia towards me. That's kind of what this is. We'll talk more about that later. But this is happening again within that joint space. You get that glide, that translation between surfaces. Because if that did not happen, a good way to think about it is you have a glide, a roll, and a spin, definitely glide and roll that occurs within the shoulder. And if those little bitty movements don't occur, we get things like impingement and labrum issues and so much more. So it's a good thing that these guys happen because it helps us prevent that. All right, a couple more. Traction. So we see this, think of like a cervical traction machine. If you've ever gone to the chiropractor, maybe this was utilized on you, who knows? But think of it, I'm increasing the joint space. So that means that I'm gonna be tugging on a bone or on that appendage away and increasing that joint space. Versus compression, guess what? I'm doing the opposite. I'm pressing inwards, or I'm decreasing a joint space. Whew, all right, hopefully your brain's not wondering like what year it is. If that is you, don't worry, go back, watch this again, go watch those YouTube videos. Convex concave roll. Now I'm going to talk you through this several different ways. I have that video for you. If you still have issues with this, please shoot me an email. I'll set up an office time for us just to meet via Zoom, and I can walk you through this, but let's just go through this together and see what we think. So convex concave rule. This is in regards to the joint space and what happens in between two bones, okay? You will have a convex portion of a bone, and this is going to be curved outward like the outside of the spear. Hopefully you guys can see my cursor. So like right here, this curve outward, okay? Versus concave will be the inside portion of the spear. So like the inside, so you have the convex and concave. Convex, concave. So let me say that again. Convex, so this is the outward curvature like the outside of the sphere, versus concave, inward, inside of the sphere. And I'll say this a little bit differently here in a second. So when the concave, I always think of this as like a cave. It's indented, you have to go into it. When the concave articulating surface is fixed, so it's not moving, it's right here. The concave, so the one that goes inward, remember concave goes inward, does not move, it's stable. Whenever the convex moves, gliding will occur in the opposite direction. Remember gliding, that was, translation, right? You have this anterior or the actual head of, let's just say that this is the humerus or the big arm bone. It'll actually rotate upwards, and then the shaft of the bone will be going downwards. If you want to try this on your body, think about how if you take your arm out and up versus replacing it down to your side, that's the movement that we're going to talk about. The joint or the concave surface is what's stable here if you're moving your arm up and down. The convex is going to be the one that is going to be your arm moving up and down. The concave is going to be the stable one. As I move my hand back down to my side, you will notice that your humerus has to slide upward and the shaft has to go downward in order to replace that arm down by my side. Let's say that again. So when my convex is moving, so that's my long arm bone, and my shoulder joint itself. So like, think of, if you're thinking about a skeleton, your scapula, your shoulder joint itself, or that socket is fixed. It's not moving. As I bring my arm up and down, the shaft of the bone or the long part of the bone is going to be moving in the opposite direction of the head or the top of that bone. Again, if your mind is melting right now, don't worry, just take this in. Next, if the convex is fixed, so that would be this one right here, and the concave, so the one that is inward, is moving, things are going to occur, and this gliding is going to occur in the same direction. Oh, that's a hard one to grasp. So again, if that curved convex surface is stable, it's not moving, the concave is that indented bone, it's going to move the shaft of the bone and the head of that bone or the top of that bone are going to be moving in the same direction. Again, please watch that YouTube video because it's going to show you in action what is occurring within the joint. Because the convex concave rule is very three-dimensional. So let's just go through some examples, some things that you can see. I already talked about this one, but let's go over it again. When the glenohumeral joint, so that's your shoulder joint, AB ducts. So that means take that arm away from your body. Gliding within the joint space occurs in an inferior direction. So that means the head of my humerus is sliding downward or gliding downward as my humerus or the shaft of the humerus goes upward. If it did not, that would cause impingement at the top of my shoulder. And that's that stabby pain that some people get, because without gliding occurring in that joint, you're not going to be able to horizontally or to be able to AB duct that arm out to the side. That gliding has to occur within the joint. Whenever you have, so your pointer finger, whenever you flex your pointer finger, gliding occurs in an anterior direction because the MCP joint has a fixed convex surface. And if you're like, oh man, you lost me there, don't worry. We'll talk about this again and again and again. I'm just planting a seed. So what I want from you is to please go watch those videos. It will help you. But just 2 points of interest here. All motions discussed occur in one of the 3 cardinal planes. So flexion extension in the sagittal coronal plane. Abduction, adduction, that's in the frontal plane. External, internal rotation or rotation along the spine occur in the transverse plane. Just point of fact. So you can kind of see how these concepts start to hold together as we bring them into this 3-dimensional space. And for motions that occur in the oblique plane, we use degrees of motion. So what that means is if we're combining different movements to get the appendage in a certain place, we almost paint coordinates for it. We talked about this from the first very get-go, the first PowerPoint. We like those coordinates to get specific, right? Forward flexion of the glenohumeral joint with 35 degrees of horizontal abduction. That's like calculus to you probably right now. Maybe you followed that, maybe you didn't. And for me, I just have to visualize it. So follow along with me, okay? So forward flexion of the shoulder joint. Remember, glenohumeral joint is the shoulder joint. So forward flexion means that your hand was down by your side. Now you're reaching it up forward towards me, towards the computer. And then in order to horizontally abduct, remember how I said that horizontal means that basically you're doing the action just out to the side of the body? Well, now we're taking that abduction, so we're taking the arm away at that horizontal space. So we've gone straight up to where our hand is in line with our shoulder, reaching out towards the computer, towards me. And then we're gonna take our hands, take our arm out 35 degrees. Everybody kind of visualize that. You can do that with me. So we brought the arm up to shoulder height and then took it out away from the body 35 degrees. That would be a motion that occurs in an oblique plane. I know we're getting nitty-gritty here, but it does help whenever you're trying to diagnose someone or get measurements from somebody whenever you're evaluating someone. Flexion of the iliofemoral joint. So guess what? That's your hip. So flexion means that we went from standing straight up to putting our weight on one leg and bringing the other knee up or other leg up to about 90 degrees. And then we have 15 degrees of external rotation. If you're like, wait, what just happened? Think of it like you took your knee outwards 15 degrees. So we rotated out within the hip joint, taking that knee out 15 degrees. So not quite to tree pose if you're familiar with that, but we rotated within that socket outwards. External rotation. Whew. So if your brain is like, I need a moment, take a moment. I invite you to re-listen to this PowerPoint again after you kind of take a walk or something like that. Maybe you come back to it the next day. But then also, don't forget these resources right here. It's on slide 19. I love these because you get to visualize this. You're not just trying to use your imagination for this 3D. I hope that you guys enjoyed this PowerPoint. Hopefully it was a little bit challenging for you. That's the goal of this. We want to start teasing movements out. Granted, we're not in the same classroom, so it's a little bit harder. We have to use, our brains and kind of imagine this instead of just visualizing in class. But I hope that this was just challenging enough to you that you're like, oh, okay, now I have to start thinking differently, because that's the ultimate goal. I want to start challenging you guys to think differently. And I hope that this helped with that. And I also hope that you don't feel frustrated. If you have any questions, shoot me an email or go back, watch these videos. They're great resources for you. If you need me, like always, feel free to shoot me an email. Otherwise, I'll see you guys in the next lecture.